Good afternoon and welcome to this month's gathering of the Northern Virginia Health Policy Forum. My name's Jim Scott, and I'm the president and CEO of Applied Policy based here in Alexandria. And my focus and the focus of my colleagues at Applied Policy is to improve the lives of people by ensuring they have access to the medicines, medical devices, diagnostics, and healthcare services they need to live longer, healthier lives. We've been doing a lot of work lately on reimbursement in the United States under Medicare and Medicaid and around the world for COVID-19 diagnostic tests. Today, as COVID-19 case numbers spike here in the US and across the world, the development of a vaccine is in the forefront of public policy. The US government has committed billions of dollars to accelerate development while maintaining standards for safety and efficacy of producing and delivering 300 million doses of safe and effective vaccines. In fact, today, the FDA is holding an important meeting about the safety and efficacy of vaccines that some of our speakers have attended this morning and will be making comments at later this afternoon. So without further ado, I know you don't want to hear from me. I'm really impressed with the panel. These three people are people who I admire and look up to, and I'm grateful that they are able to take the time to participate in this event today. Dr. Gary Puckrein is a longtime friend. He's a president and chief executive officer at the National Minority Equality Forum. The forum's a research and educational organization dedicated to ensuring that high-risk racial and ethnic populations and communities receive optimal health care. Dr. Puckrein leads the organization in its work to strengthen the capacity of local communities to eliminate the disproportionate burden of premature death and preventable illness in minority populations. Welcome, Gary. Sue Peschin is President and Chief Executive Officer of the Alliance for Aging Research, the leading national nonprofit organization dedicated to accelerating the pace of scientific discoveries and their application to improve the experience of aging and health. As a thought leader on many aging-related issues, she's led the Alliance in efforts to boost older adult immunization rates. And Dr. William Schaffner is Professor of Preventive Medicine in the Department of Health Policy, as well as Professor of Medicine in the Division of Infectious Diseases at Vanderbilt University School of Medicine in Nashville, Tennessee. Dr. Schaffner's primary interest has been the prevention of infectious diseases. He's worked extensively on the effective use of vaccines in both pediatric and adult populations, and has been a member of numerous expert advisory committees that establish national vaccine policy. All of our speakers have been quoted in the national media, and I encourage you to use Google News to look them up and see what they said, because it's really insightful. But for you today, we have them here live. And I'd ask each of the panelists to provide an opening statement. And so since I introduced them, Gary, Sue, and Dr. Schaffner, let's start off with going the reverse order and have Dr. Schaffner start and set the stage, and then we'll have Sue and Gary react with their opening statements, and then I'll jump into some questions. So take it away, Dr. Schaffner.
So hello, everyone. Thank you, James, for your nice introduction. It's a pleasure to be with you. And we're at a critical point here regarding COVID and incipient influenza. Immunizations are at the forefront of the news. How very interesting and unexpected. So what's happening across the country troubles me. We're seeing an uptick in COVID in many, many parts of the country, including my own. We had a conference just this morning. We had things going pretty well in Nashville, but they've ticked up, and Tennessee, I think, ranks 6th in the country in regarding new case rates. This virus has moved out of metropolitan areas into the suburbs and now into rural counties, where it is spreading really in a rather uncontrolled fashion. And the weather's getting a little colder, and what's coming soon? Our old friend, our old enemy, influenza. And we're all worried about a twindemic. This is influenza vaccination season. I want to emphasize how important it is for everyone age 6 months and older, particularly apropos of Sue's being with us, everyone age 65 and older to please get vaccinated against influenza. That's something we can do for you and the people around you right now, and it will take some strain off the healthcare system. We're interested in vaccinations across the lifespan, but the emphasis at the moment is influenza. And then, of course, we'll all have questions about COVID. Glad to help.
Thank you, Dr. Schaffner. Sue, can we turn it over to you?
Sure. Thanks, Jim. And thanks for having me on this panel with Dr. Schaffner and Dr. Puckrein. It's a pleasure. The Alliance for Aging Research, as Jim stated, is a national nonprofit group. We've worked in the issue of older adult vaccine education for a number of years now through our campaign, Our Best Shot. And this year, as Dr. Schaffner mentioned, it's more important than ever that older adults get their recommended vaccines. First and foremost, flu, but if your doctor recommends pneumonia vaccine as well, both of those conditions can really complicate COVID-19. And so if they're recommended by your doctor, you should go get them. In fact, Dr. Schaffner's group, the National Foundation for Infectious Diseases, just did a review, and vaccines are down across all age groups by as much as 80 to 90% in certain groups. And so regular vaccination is key to prevention. And we really want to encourage people to do what they need to do to take care of their health, to be ready for when COVID-19 vaccines are available. On that note, we also want to make sure that the vaccines that are coming to market are safe and effective for all groups, that all groups are adequately represented in the clinical trials, particularly those most at high risk, older adults, minority populations, a lot of older minority adults in particular. And so we're working on issues around FDA safety and efficacy, making sure that they're going to be adequately covered when they are available, and just making sure that people are confident in the regulatory system that we have, the long-standing regulations and checks and balances that we have in the system, that FDA stays independent, and that we take politics out of science. Thank you.
Thanks, Sue. And Dr. Puckrein?
Thanks, Jim. So everyone knows that COVID has had a disproportionate impact on minority populations. African Americans have higher hospitalization rates and higher mortality rates, and it is symptomatic of health disparities that have been a long-standing problem in the American healthcare system, and COVID is just really dragging them out into the open. And some of that is even, quite visible in if we start with flu vaccines. So in the flu vaccine world, about 41% of African Americans are receiving the flu vaccine, and it's about 30% lower. The rate is about 30% lower than whites. Even in the Medicare program, we see that minority populations, seniors, are not getting the flu vaccine, and even worse, they're not getting the high dose. The high dose, I believe, is somewhere around 17% of African American seniors are getting the high dose vaccine. And all of this has consequences. If you look at CDC, just released some numbers actually yesterday or the day before that said the hospitalization rate for flu among African Americans was about 68 per 100,000. By way of comparison, for whites, it was about 32 per 100,000. So we're seeing the problem. And some of that in the flu vaccine is actually structural. There are some changes that have been happening over the last couple of years with how flu vaccines get administered. Historically, it was in the provider practice, which meant that the provider had to pay for the vaccine before he could administer it. And there was some vaccine hesitancy in the minority community, which created reluctance on physicians to actually purchase the vaccine. But even more importantly, there's a whole historic tradition of African Americans not having health care before ACA. About 48% of African Americans had no health insurance, and about 54% of Hispanics had no health insurance. So it's hard to argue to get a vaccine when the tradition has been that you have not had access to healthcare. Now, when we add COVID to the mix, right? So you've got a whole tradition of under administration of flu vaccines, and I could throw pneumococcal in there, which is even worse. And now we're talking about a COVID vaccine with a whole lot of discussion about warp speed and everything else and the politics around it. And so there are all kinds of concerns that are being raised about the vaccine as it comes forward and is going to be administered. First of all, and I think there is some evidence that there's some attempt to make sure that the trials are diverse, because we'll need those numbers to make sure that the vaccines are safe and efficacious for all populations. But even more importantly, is to persuade African Americans and Hispanics that they should take the vaccine. I think the numbers are at least 50% are saying that they wouldn't take the vaccine if it became available. So we have a lot of work to do in order to make those vaccines available to population, because we haven't talked about how they're going to get paid for, and then conversations about persuading people that they actually need to take the vaccine.
Thanks, Dr. Puckrein. So you mentioned that data are showing that minorities are much more susceptible to becoming seriously ill and having higher mortality rates when they're infected with the COVID-19 virus. And with the clinical trials going on now, do you feel like there's adequate minority representation in the current clinical trials? And if not, do you have some tactics or examples of what you think should be done to increase minority participation in those trials?
I know some of the sponsors of the trials are making effort to have diverse populations in their trials. I've not seen any numbers about the breakout of the demographics of those trials. I just know that there is some effort being undertaken to make sure that they are diverse. But I think that's really sort of the beginning of the conversation. Even if they are diverse, these are not large-scale studies that are being undertaken, which is what is traditional to vaccines. And so there needs to be some real work explaining to people what warp speed actually means. How has it changed how we test for safety and efficacy with vaccines in a short period of time? I don't see any of the manufacturers having really taken the effort, or even government for that, to help the public understand what warp speed actually means and how is it different in terms of time, but keeping all of the safety and efficacy in place. And I think those are conversations that are going to be important to not just minority populations, but I think to the general population as well.
That's an important point. I was struck by calling it Operation Warp Speed, and to me that can cut both ways. You can get it fast, but maybe not, check all the boxes and ensure it's safe and effective. I'd like, Dr. Schaffner, do you have thoughts? Should we trust a vaccine that's approved through something called Operation Warp Speed?
Well, I think you and Dr. Puckrein are exactly on target. When we say Operation Warp Speed, a lot of people hear, oh, they're cutting corners. They're not realizing that we're doing things simultaneously that we used to do in sequence. The most dramatic change has been that although the clinical trials are currently underway, and we don't know yet whether these vaccines are effective or how effective and how safe, nonetheless, we are already manufacturing large amounts of vaccines, and they're being stockpiled in warehouses so that should things work out all right, we'll have vaccines ready to go rather quickly. And you and I and everybody else in this call has invested in that because the US taxpayer has paid the companies monies to actually start manufacturing these vaccines. There's a terrific amount of anxiety and skepticism out there, not just in the general population, but in the medical community also. So I think much more communication is important. When we get to the point that we actually have a vaccine ready to use, I think it will be imperative that the the Food and Drug Administration's advisory committee is explicitly involved in giving their thumbs up to the use of this vaccine, that the data are presented up front very, very clearly so that medical professionals can see it and can then provide reassurance and urge their patients to actually participate when it comes their time in the prioritization scheme. So, as we all know, communication is terribly important. It has not been optimal. And I would hope that when we get to the point of actually presenting the vaccine, this may be a vain hope, but that the politicians stand back and let the professionals, the public health professionals, take center stage and present the vaccine. That would help enormously in relieving some of the skepticism and anxiety that people have. And having said that, just to reinforce something that Gary has said, we have, by the national surveys, data to indicate that lots of people, as many as half the population, are skeptical. That proportion is larger in people of color and people of lower socioeconomic standing. And so these populations which are disproportionately affected by COVID need particularly attention to reassure them and provide them the information that will make them comfortable in actually seeking out the vaccination. We have a lot of work to do. Thank you.
Thanks, Dr. Schaffner. And Sue, in your opening remarks, that you mentioned the Alliance's Best Shot campaign. Now that we've had some reassurance from Dr. Schaffner that the FDA is still doing its job without undue influence, what do you think about, how will the Alliance's One Best Shot campaign play a role? And could you say a little bit more about that?
Sure. The Our Best Shot campaign has created a number of educational materials over the years, including fact sheets about how to deal with common myths regarding vaccines, information about Medicare coverage of different vaccines. Right now, we have a PSA campaign going on TV, digitally, on Facebook, just to do the messaging that we talked about at the beginning. Everybody get your flu shot. Let's get ready for a COVID-19 vaccine. But we're also going to be doing some work with HHS, which is coordinating directly with Operation Warp Speed. And that sounds like a very sort of separate entity from government, but it is working, I think, pretty integrally with HHS, with the FDA, with NIH, with BARDA, which is another research entity within the federal government, to try to coordinate, to try to make a plan around distribution. I do agree that there needs to be more information out there about what it is. There's a page on the HHS website right now, but they're in the process of putting together a portal of all the different research studies that are currently recruiting in vaccines and therapeutics and in convalescent plasma, because we still need people to donate who have gone through COVID-19 and also to study it. And I completely agree that we need more education about what that is, how it's separate from FDA. Operation Warp Speed doesn't approve vaccines. The FDA does. and they take guidance from their advisory committee, as Dr. Schaffner mentioned. All of that needs to be laid out to the public in a simplistic way. Putting out the regulatory guidance that's given to industry is not something that the average consumer is going to sit down and read, a 20-page document that's technical. So they need to really make it simple so that people do feel confident and feel like they can trust the process that's going on. And I think companies and groups like ours, mine and Gary's, and all the whole community needs to work together, and we need to have consistent messaging, and we can divide and conquer for our different constituencies, but we really need to have consistent messaging that is supportive of people getting safe and effective vaccines, that's supportive of a good, strong regulatory process.
Thanks, Sue. So I'm going to take some questions from the audience that I'm seeing here in the chat and turn it back to Dr. Schaffner. So I've heard, we've talked about, will the vaccine be safe and effective? And then people are individually talking about whether they're going to get it as soon as it comes out. But will everybody really have the chance to get it, the vaccine, as soon as they announce one's been approved, or will there be likely to be a prioritization system? And what do you think the prioritization system will or should look like?
Well, Jim, there clearly will be a prioritization system because we won't have enough vaccine ready, even though we've manufactured vaccine for everybody on day one. A variety of groups have looked at this, and I think the final arbiter will be the CDC's Advisory Committee on Immunization Practices, which incidentally is meeting next week and probably will settle on a prioritization scheme. Almost everybody agrees that first in line will be healthcare providers who have direct contact with people who have COVID or are likely to have COVID. And so the hospitals and emergency medical systems and others will be delivering that vaccine according to each state's plans by a distribution system of the vaccine that will be equitable across the various states. What happens next is still a little bit under discussion. There are kind of two big options that have been discussed. One is to give it to essential workers, people who keep this country going, whether they work in the local supermarket or are long distance truck drivers or work in the sewage treatment plant or whatever. People who keep this entire community, all of our communities functional. A lot of those people also are people of lower socioeconomic standing, people of color, people of a variety of ethnicities. So it would be a way of reaching that population. The other thought that has been expressed is, once we do the healthcare workers, we ought to go to the populations most substantially affected. People age 65 and older, people with underlying illnesses, and people in communities of color and ethnicity. So there's kind of been a discussion back and forth. I have no idea how that will settle out. I don't think there's a right answer. I also don't think there's a wrong answer. Some people like red Chevys, other people like blue Fords. As long as it is clearly expressed, the rationale behind it is expressed, and that it is ethically validated, and medical ethicists have been involved in this, as well as consumer, that is patient focus groups have all had a chance to impact this discussion. So we'll find out the end of next week. The actual delivery of the vaccine will take months. And I would just add as a footnote, the average person thinks of the vaccine as somehow a suit of armor. Once they're vaccinated, they're protected against COVID. They don't have to worry about anything anymore. That's incorrect. And we've not done a good job in expressing that. The vaccine's not likely to be 100% effective, or nearly so, the way tetanus vaccine is. it's more likely to be like our flu vaccine, kind of effective. Let's just say it's 75% effective. Not bad. From a public health standpoint, we would like to see that used. But that does mean of every 10 people vaccinated, 3, and we don't know who those 3 are, probably will remain susceptible, even though they've been vaccinated, or largely so. We'll still have to wear the masks, do social distancing for months into the future. Months. So let's not get too restive about trying to get rid of the masks and yearning to go back to the old normal. The virus is with us. It's going to stay with us for a long time. It's much tougher. This is a long haul, not a short race. Thank you.
Thanks, Dr. Schaffner. Dr. Puckrein, do you have thoughts on how a prioritization system ought to work, and maybe comment on Dr. Schaffner's views?
Obviously, this is going to be a really touchy subject. We've gotten ourselves into one of these places where you're sort of damned if you do and damned if you don't. So if you prioritize minorities, they're going to be suspicious and say, you're giving it to us because you want to test it out and see if we grow horns first. And if we don't grow horns, then you can give it to everyone else. Trust me, it's going to be part of the conversation. And so I think the big issue here is trust. We've lost trust of the American population, and we've got to figure out how to get it back. I mean, that's really, at the end of the day, the first business that's got to happen. What I would also say, and we haven't talked a lot about it, is this vaccine going to be free? And so that's another big conversation. How are we going to pay for that vaccine? Is it going to be free to everyone? And what happens if it isn't free to everyone? Are we going to end up with a black market in the vaccine world? I mean, there are lots of really troubling things that happen here. Are we going to have a national policy, or each state is going to have a policy? And that'll create its own level of confusion. And I think Dr. Schaffner also pointed out the vaccine ought to be one piece of a larger plan where we continue to social distance, wear the mask, use the vaccine, target hotspots, and all of those kinds of things in order to successfully manage the virus and get ourselves back to some sort of normal. If the understanding is the vaccine, as some suggest, is going to immediately take us back to our former lives, it's not going to happen. So I would end with this, particularly for the minority community. The conversation really needs to start now, and both with the physicians who are providing care to them, as well as to the community at large, to prepare them. And that preparation can start with the flu vaccine, because guess what? We're not doing a very good job with the flu vaccine right now with them. So if we can start with the flu vaccine, we can work our way towards the COVID virus vaccine.
Jim, I just want to add a comment about the whole coverage and paying for the COVID-19 vaccines.
Sure.
The federal government, you keep hearing about these deals with the manufacturers, 100 million vaccines. A lot of the COVID-19 vaccines, in fact, the majority of the candidates require 2 doses. So that's really 50 million people, which is not tiny, but it's not everybody. The approval that's likely to come at first is not a true full approval, which Medicare doesn't cover. So emergency use authorization for either vaccines or therapeutics are not covered by the Medicare program. Once they run out of the government funded vaccines, they have to kind of figure out how are they actually going to cover these, or are they going to end up charging people? And also under emergency use authorization, it's allowed sometimes in hospital settings, doctor's offices, for there to be administration fees charged. So it's an interesting issue that I think it's just going to get more discussion as the first EUA happens, but it's pretty significant what Gary is talking about.
Thanks, Sue. And, it's so I would expect with all the COVID relief bills that Congress may change the rules to either promote access or waive some Medicare requirements, but that's not yet been decided. And we're going through an election in November, and there could be different approaches depending on how the houses of Congress come out and also who wins the presidency. So to add to the uncertainty of the merely scientific development, as much as you like to have politics be out of it, it looks like politics is going to continue to play a big role on the accessibility to the vaccine. And interestingly, Medicare only covers 3 vaccines under its Medicare Part B, and then the other vaccines come under Medicare Part D as in dog, which has a very different copayment structure. So without congressional action, the flu vaccine is one of the ones that people are used to getting that Medicare covers under Medicare Part B. And that's not where the COVID vaccine will be without congressional action or some kind of waiver of current laws. So definitely there's more to come on that accessibility and affordability, and it's far from a done deal. This is a good question, and we've been doing some work in Europe and around the world on access to the diagnostic tests. And so once the vaccine comes out, the pandemic is global. So how should we view the distribution of the vaccine across the globe relative to just making sure we get what we need here in the US? Dr. Schaffner, do you have thoughts?
My thoughts actually, Jim, are very limited, other than to say we need to have plans in collaboration with other countries in the World Health Organization and other international organizations, because the goal really ultimately is to immunize the world's population against this virus. I don't know what any of those plans are. That's, as they say, above my pay grade. I know that it's been a matter of discussion clearly among lots of people in public health who would like to know on a practical level how vaccine will be allocated, whether it's manufactured in our country or in others, and how that vaccine will be distributed. I'll be fascinated if my colleagues have some insights. Thank you.
Gary or Sue, any thoughts on the sharing with the rest of the world or just keeping it for the US?
I would have to join Dr. Schaffner and say way above my pay grade on that one. Obviously, very complicated question. We already see hoarding between states. It's going to make matters extremely problematic, but I have no real answer to that.
Here's a question I've been meaning to ask since the beginning. And let me go back to Dr. Schaffner. What are the characteristics of the vaccine candidates? Like we have a question here: Are they MABs, monoclonal antibodies, or what are they? What's their how are they made, or what are they made of? But also, sort of more importantly, is there only going to be one COVID vaccine, or are there likely to be multiple vaccines approved? And then how will we know whether we're getting the good one or the just okay one?
Lots of wonderful questions. Let's start with the biggest picture of all, what's happening around the world. There are over, as I understand it, over 120 scientific groups around the world trying to develop vaccines. And isn't that wonderfully innovative and a scientific focus on this problem which faces the world's population? And different countries, as you may have heard, already have vaccines in various stages of development. The Russians and the Chinese are fairly well advanced. Even before their effectiveness trials are finished, some of those vaccines are starting to be delivered to their populations. Here in the United States, we have about 5 companies, 5 or 6, that are close to the they're in the lead as far as the vaccine development process is concerned, and they have a variety of different ways of developing the vaccines, some of which are rather new technologies for which there's no precedent for a licensed vaccine in this country. One of the more imaginative ones is to use mRNA vaccines. So the RNA is actually injected into the cells in our arm. That's integrated into the cell. Those genes actually take over the cell's metabolic mechanisms to develop the spike protein that's out on the surface of the virus. So our own body makes the actual vaccine, which is the spike protein antigen against which our body then develops antibodies. It's very, very clever. One of its great advantages is that you can develop this vaccine very, very rapidly and make large amounts of it. And a disadvantage is that these vaccines are a little bit unstable and they require very secure storage and handling facilities. One of them actually requires the vaccine to be stored at -70 or -80 degrees centigrade. So it's not the sort of vaccine that can be distributed widely to the average pharmacist or clinic or doctor's office. So each of them has their own kind of characteristic. We anticipate that there'll be several vaccines. And it's already been said, I think it was by Sue, that most of the leading vaccines require 2 doses separated by either 3 weeks or a month. So we'll have to develop national record-keeping systems so that you get your second dose of the same vaccine that you got the first time, because there'll be no data on mixing and matching. The CDC will also have several surveillance systems in place nationally to assess vaccine safety in use. Once the vaccine is given to hundreds of thousands and millions of people, we're going to continue to monitor for rare adverse events putatively that then will be investigated. And we'll also set up systems to assess for how long the protection lasts, because we won't know this at time zero. So once we start using the vaccine, there'll still be lots of questions that need to be answered. And you know, that's true of vaccines normally, but the public is newly acquainted with this and will be much more interested in the phenomenon. And given that we won't have all the answers, we'll need to absolutely reassure people that these systems are in place and are expansions of what it is that we normally do.
Jim, I just want to jump in on one point. We're talking a lot about the vaccine, but there's a lot of infrastructure that's going to come with the vaccine. So we talked about providing the vaccines to essential health workers. How are we going to document that they got the vaccine when they go for employment? If you talk to the airline industry, they'll want to know who has the vaccine, who's been vaccinated, or whatever. Restaurants, for their employees, will they require them to be vaccinated, and how will we display that? And that gets into databases, and all of a sudden we've opened the door up to, are we going to have Google and Apple running around with our health information? So there's a whole lot of back end stuff that's going to happen here once we open that door to the vaccine, and trying to make sure that we're able to communicate who has had the vaccine, and the presumption is that they have a lower risk for the virus.
I just wanted to say 2 things. If anybody wants to geek out on the different vaccine technologies, the Children's Hospital of Pittsburgh, Paul Offit heads up all the work that they do in vaccines there. And there's great information that sort of walks you through all the different types of COVID-19 vaccines, so you can learn more about that. And then related to Gary's point, I just wanted to say, probably a lot of people saw in the news, there was a deal with 2 big retail pharmacies to distribute vaccines to nursing homes across the country late last week. And there were concerns brought up by consultant pharmacists which are trained in geriatrics. They're trained in delivering vaccines to older adults. And it's not, sort of an easy thing that you just sort of breeze in some of the most complicated populations medically to just give them these vaccines. So it is really important to be thoughtful and not just rushed about the whole process. Yes, we want something as soon as possible, but we don't want it done in a way that compromises the individuals it's supposed to help.
So two little points, if my colleagues will permit footnotes. Sue, I think it's the Children's Hospital of Philadelphia, which is where Paul is. And the other thing is, I've been told by attorneys, Gary, that because this is a vaccine under an emergency use authorization, you can't mandate it because it's not a fully licensed vaccine. I don't know that for sure, but that's what I've been told. Apropos of who gets which vaccines, the vaccines registries that exist in every state are being ginned up to manage this so that you ought to be able to get your first dose from one provider, go to another provider for your second dose, and that second provider can access the vaccine registry and figure out which vaccine you've gotten. That sounds ideal. We're all a little skeptical because we know the vaccine registries across the country are not all perfect and they don't all talk to each other. So we'll see how that works, but that's yet another challenge that's before us.
Dr. Puckrein, you mentioned one of the big problems is lack of trust, and lack of trust, particularly among African American and Hispanic populations is, well documented and justified. Do you have any thoughts on what more can be done to improve the trust, even in this environment where everyone has sort of a question about who should they trust?
Yeah, I think this is really one of conversation and bringing everyone along through the process. We don't typically, when we are developing therapies, engage the population, the broader population, in how that process is working. We see it as it comes out the completion door. But here, I think that there's a real need to make sure that along the way, the public is brought into the conversation, that the trusted voices in the communities understand, because the point of the vaccine is just not that it's personal, it's also a public health vehicle, which is going to provide better opportunities for the total population. And so given that, I think it's just really important to start that conversation now. And when you look at the sponsors of the trials and the developers, they're not accustomed to doing that. They're not accustomed of having that conversation. And as Sue pointed out, their tendency is to put out information that is, for experts, but not for the lay public. And so I think the moment is really now to help people understand what a vaccine is and is not, and what they can expect and how safe will it be. And if it's not safe, what happens to them? We haven't talked about that. So if the vaccine, for whatever reason, you get a bad outcome from it, how do we plan to help that population?
Sue, how's the trust level amongst older Americans, and is there better communication? Because it looks to me like if you're in a nursing home, you're teed up to be first. So it seems like, along with the kind of same view Gary said, is like, hey, you're putting us first, we're lucky, or you're putting it first because we're expendable. And you could read it either way. So what do you think about the senior population?
Yeah, I mean, in general, the senior population tends to have good rates of compliance. It does vary based on race, to Gary's point, and some of that has to do with trust in the system. It's not the same as children. Compliance with child vaccination is much, much higher because there are mandates around that for going to school, to Dr. Schaffner's point, for other approved childhood vaccines. But I do think that there's definitely a worry. 80% of the COVID-19 deaths in the United States have been among older adults, 65 and older. And they represent about 16% of the population. So I think it's pretty widely recognized that long-term care ought to be up front or towards the front. But that being said, my group, the Alliance for Aging Research, really wants to make sure that it's not necessarily just the first vaccine that gets looked at by the FDA, but rather the one that's most effective for them as a population, because older adults, their immune systems grow weaker with age. And so the response to standard vaccines tends not to be as strong. And there are enhanced vaccines that have been designed for older adults in shingles and in flu. And there is at least one candidate in COVID-19 that is enhanced. But it's going to remain to be seen with the more standard dose ones if they're going to produce enough of a response to be as effective as possible for older adults.
So, Dr. Schaffner, you mentioned earlier that, which was, I sort of knew this, but I didn't really want to believe it, that a vaccine wasn't a pseudo armor. And even though I got my flu shot, there's still a chance I could get the flu. And it's always been that way. Every year I got the flu shot, but I should still get my flu shot anyway. So and with the COVID vaccine, I understand that it won't work for everybody, but if it does work, are people who are vaccinated able to carry and transmit the COVID virus, and they just don't get sick themselves, or are they not able to transmit the virus if presuming they're in the hopefully 75% that it worked for?
Well, let's start with influenza vaccine, Jim. So we all know that influenza vaccine is not perfect. It's a good but not perfect vaccine. I like to hearken back to that old French philosopher Voltaire, who admonished us, waiting for perfection is the great enemy of the current good. The vaccines we have today against influenza are the best in 2020 that science can produce. So let's use them. They protect against thousands upon thousands of infections completely, avoid hospitalizations and deaths. And even if you happen to get genuine influenza after having received the vaccine, you get an added benefit because your illness is likely to be briefer and much less severe. You're less likely to have to be hospitalized. You're less likely to die. Hello, what's wrong with that? So I think we need to promote influenza vaccine throughout the population even more. Now, apropos of COVID vaccines, we all know that, or we anticipate that these vaccines also will be partially effective. I don't think anybody expects these vaccines to provide 100% protection. Now, if we look at these clinical trials, it's not quite clear whether we will have endpoints that let us definitively understand at the point of the decision to use them, whether they will prevent infection or just severe disease. Could it be possible that we could be protected against severe disease, but still could transmit the virus? If that were true, even more reasons that everyone would have to keep masking and social distancing until we got everyone vaccinated. It would be a huge public benefit, public good, if we could prevent severe disease, of course, and by extension, deaths. But the public health interest in also interrupting or reducing transmission may or may not be part of what the vaccine provides. pneumococcal polysaccharide vaccine prevents serious disease, invasive disease, bloodstream infection, and meningitis, but doesn't have anything to do with carriage. So the pneumococci can still spread. Pneumococcal conjugate vaccine, on the other hand, not only prevents serious disease, but it interrupts carriage. One of the reasons we're using conjugate vaccine now universally in children. So we'll have to see which kind of vaccine we get here.
Get ready to wrap up, but one more question. Some of us have young people at home that are, all the news says are, not at a big risk of getting ill. So how do we explain to them that even though they're not at a big risk of getting a severe illness, and they may not have any symptoms, they still need to socially distant and wear a mask, and why that's important?
Well, I think you're still looking at me because they can be dreaded spreaders. And that's very, very important. We know that they are very effective in spreading the influenza virus. It may not be quite the same with COVID. We know that they can get infected. That's something we've learned over the last several months. We know also that from time to time, even a young, healthy person, or young child, or young adult can be badly, really badly affected by COVID and put into the hospital and be at risk of dying. And indeed, among young children particularly, we're now concerned about the multi-system dysfunction syndrome, right? And so it's not as though children are ollie in-free. We want them to protect themselves, even though their risk of serious disease is less. And we also don't want them to contribute to the spread. They'll have to wear the mask, just the way we do.
Thanks. And so let's go for a round of final thoughts. So if there's one thing our speakers want folks to remember today out of all this insightful conversation, now's the time to let them know. So let's start off with Sue.
If you haven't done so already, get your flu shot by the end of October. If you're older than 65, check with or you're in a high-risk group, check with your doctor to also see if you need a pneumonia vaccine. Wear a mask, wash your hands, keep your social distance, don't congregate in big groups, and just, keep reaching out. Stay socially distant, but not, but stay connected to people.
Thanks. And Dr. Schaffner, your thoughts?
I would say disease bad, vaccines good. When in doubt, vaccinate. Emphasize again what Sue has said. This is the time to get vaccinated against influenza. Also consider pneumococcal vaccine. You may be eligible for that. And beyond anything else as regards COVID, please, everyone, the moment you leave your front door and you're around people, wear the mask, keep socially distant, avoid large groups, and please, everybody, stay safe.
Thank you. And Dr. Puckrein, you get the last word.
So I'm going to say what we all know is so. Policy is part of healthcare. It is a very important branch of healthcare. And one of the parts of policy that's really important is the vote. We have to have a national system. In order to combat this virus, it doesn't matter about the vaccine. I mean, it's important. The mask is important. But what's really, really, really important is that we have a plan, right? We got to have a plan, right, for the whole country. And the only way we get to that plan is that we got to vote for it. I mean, it's fundamentally the point. There are lots of ideas out there on how to manage the vaccine, and I'm not going to tell you which one is appropriate, but I am going to say to you that you're going to have to vote for the one that you want, because at the end of the day, we just have to have a plan.
Well, my thanks to the all three of our speakers. This was a really excellent session, and I really appreciate the opportunity for everybody joining in our audience to hear the unfiltered views and with sort of the no spin zone. So that was what I was hoping for, and I'm glad that the three of you delivered. Thanks again, and stay tuned. We'll be having another event next month, and if you're not on our list, let us know and we'll make sure you get added. But thanks again to our three speakers, and appreciate the audience's virtual applause for them.